Ocala's information station, 1370 WOCA.
Ocala.
All right, 5 minutes after 11 o'clock. Thank you for tuning in this Thursday morning. Nice looking day out there, and it's the first day of March. Everybody, all the other newscasters, Robin, is saying in a few hours it'll be March. All I knew was it was today. I know nobody told me the time it was going to start.
That's right, for spring, yes.
For spring, I'm sorry, not for March. Anyway, it is March, and it is also March is Colorectal Cancer Awareness Month. Woo-hoo! Who's celebrating that? Anybody? I don't know who's celebrating that. We all should. We're going to learn it. We all should. Is that what you're saying? Dr. Angel Caban is who you just heard right there. I hope I said your name right, Doctor. How'd I do?
You did pretty good.
Close? Oh, not good enough. Okay. Well, I'll get it by the end.
You need to get the Spanish accent going.
Oh, Caban?
Caban, yeah.
Caban.
Oh.
Caban. Well, it took me like a year to get Brittney's name, so I think Caban will be easier. Dr. Angel Caban is a general surgeon at Ocala Health Surgical Group. Phyllis Anderson is here as well. She's a patient navigator at the Cancer Center at Ocala Regional Medical Center. Kelly Ryan is here. She's a practice manager for Ocala Health Surgical Group. And our good friend Brittney Marthaler is at the end of the table. Got it, right?
Perfect.
Got it finally, right after all this time. So don't feel so bad, Doctor. So we're going to talk about this kind of a difficult topic. Cancer is always a difficult topic, but that part of the body is really a difficult part to talk about, isn't it? For me anyway. Good morning, Doctor. How you doing?
Good, on yourself?
So what do we need to know about this? Do you and I have always wanted to know about this, by the way? Does spicy foods cause a problem?
Well, there's a lot of risk factors for colon cancer.
There is?
The diet is definitely one, especially our very unhealthy diet that we eat pretty much every day. And so in America, colon cancer is a big problem because of our
because
diet,
of our food.
our weight. Smoking is a big risk factor for colon cancer. So.
Yeah. So colon, help me understand, what is the colon? I think I know, but maybe I'm wrong.
So the body has the small intestine and the large intestine.
Right.
Both of them have different functions. The main function of the colon is to absorb most of the liquid that is in the stool to form a more solid stool.
Oh.
That's kind of one of the main functions of the colon. It absorbs some electrolytes as well. But that's kind of like the main function of the colon is to solidify the stool. So when you go to the bathroom, you don't waste all that fluid that you need.
Okay, so you need it to be absorbed.
Mm-hmm.
Okay, and when cancer starts to develop, is it not doing that anymore?
Well, it still, for the most part, does the function that is required, but usually cancer starts with like a small polyp. It's a small mass that starts to abnormally grow and eventually can cause dysfunction of the organ that is invading. In this portion is the colon. Usually they present with bleeding. That's kind of like the most common presentation, some sort of anemia or weight loss. If it's big enough, and depending on what portion of the colon it is, they can become obstructive. They can block the passage of stool.
Oh, that's not good.
So it can be, later in the stages, it can be an emergency that needs to be taken care of.
Does the person with what do you call a polyp?
Mm-hmm.
Does that person feel it?
Most of the time they're asymptomatic.
Okay.
You just find it either by screening. If you, at the age of 50, you're recommended that you undergo some sort of screening for colon cancer. A lot of times it starts a small polyp, you biopsy, take it out, and most of them are negative, but some of them had pre-malignant changes, and then from there it becomes, if you never had screening, you can develop like a large mass.
Since screening is recommended at age 50, does that mean that the chances of having it before that is very slim?
So it's lower. Usually we recommend screening earlier than age of 50 if you have like a family history. Let's say your dad died of colon cancer at the age of 55, and his brother died of colon cancer at the same age. You should get screened at least like 10 years before the time that they got diagnosed, so at age of 45. If you have other conditions like inflammatory bowel disease, like Crohn's disease or ulcerative colitis, those people are more predisposed to develop cancer. So they get screening more often at younger ages. So,
if somebody had a genetic history in their family of colon cancer, and then they moved to a country where there's not as much colon cancer, their diet changed simply because of their new culture, would that affect them in the positive way, or not really?
I don't think so.
No?
I think they still genetically predisposed to develop cancer, so they should, follow.
Okay. So I guess what I was trying to really ask is, can we change our diet to improve our chances of not getting it?
So you can. If you look at parts of the world, like stomach cancer is it's very prominent in Asia, and it's not as prominent here in the U.S. And colon cancer is kind of vice versa. So if you grew up in the U.S. and then you move to another country where colon cancer is not as prevalent because of your diet, then you kind of decrease your risk. But that's just an environmental thing. The genetic is with you. Those are your genes. You're carrying them no matter where you go. Right. So in that case, you gotta, kind of get screened no matter where you are.
So Phyllis, do we go to you first for the screening, or do you direct us where to go after we've already been diagnosed with a need for a doctor?
Well, see, in the hospital setting that I'm in, I usually meet the patients maybe before they get the biopsy done, but generally if surgery's involved, it's after the biopsy is done. Not necessarily that the diagnosis has come back, but they have been biopsied.
Oh, really? So what do you do in the meantime, waiting for the diagnosis?
Yeah, I can take like 48 to 72 hours to get a final pathology report back. But I meet the patients so that I can discuss some kind of options, help them emotionally get through it, determine what kind of barriers they might have to care, whether it's financial or resources, things like that. So I kind of guide them through it.
Is it mostly men?
No.
No, it's not mostly men.
No.
Okay, why do I think it is? Is that, do we not do a good job with public relations to let the general population know this is?
For the most part, usually females are actually more compliant about going to the doctor.
That's the problem.
A lot of males are diagnosed later because they don't complain. They've been having rectal bleeding or something like that, and they don't say anything. And eventually they make it to the doctor because their wife carried them to the doctor and said, no, you got to get this checked out. So a lot of times, a lot of diseases are more prominent in females just because they actually go to the doctor, not because they're more prominent in females.
Oh, I gotcha. Okay.
And Phyllis, do you help with the families also? Do you speak with them as well as the patient?
Yeah. Sometimes it's just a matter when they're first hear the C word, the big cancer word.
Yeah.
They're so overwhelmed with that. So we just deal with that emotionally at first. And then I help them guide through what steps or what comes next and make sure they get their follow-up. And because when they leave the hospital, then they'll have to eventually go to a medical oncologist or radiation oncologist or whatever's recommended.
Right. And gosh, give us a worst case. Well, worst case would be somebody dies, obviously. But is the colon ever totally removed?
In some cases. For colon cancer per se, it depends on where the location is. It's usually the treatment of choice is surgery. It's the only way you can get cure of colon cancer is by having an operation and get it removed. After the operation, depending on if it's involving the lymph node or other organs, you might require chemotherapy or radiation or another operation. But depending on what portion of the colon, that's the portion of the colon that we usually take that segment out.
Right.
There's some patients, not the majority of them, probably the minority, where they have a lesion in the left side of the colon and another one on the right side of the colon. Those, most of the time, require the entire colon removed. But for the most part, it's usually an isolated lesion in one side of the colon that you can segmentally resect.
So and is that when they have the bag on the side?
So they could have a bag. That's kind of like in a patient-by-patient basis. When I talk to the patients about surgery, I always have to mention that. And obviously nobody likes to hear that. But it's more of an insurance policy in some cases. Let's say if you have a colon cancer on the right side, most of those operations, I will tell you, my hands, 99% of those operations, I can do them laparoscopically. And the chances that you're going to require a bag after surgery is very low because that operation, probably for colon surgery, is the most straightforward surgery.
Really?
It heals better. the closest the colon cancer is to your anus, to the rectum, the lower it is down in the pelvis, that makes the operation more difficult. And usually if you do the connection very low in the pelvis, you have like one chance to have that to heal okay. If it doesn't heal and it leaks, then the patient might end up with a bag forever. So sometimes when the anastomosis is very low in the pelvis, we do a temporary bag, or kind of like an insurance policy bag, where we let the other connection healed up, and then eventually we take the bag away so they can heal okay. It's just trying to prevent a catastrophe.
I'm not trying to make light, but I this is my job. If I had a bag for temporary and somebody said, that's your insurance policy, you better change insurance company. don't want that. Brittney, are we okay with taking phone calls? Yeah, okay, so if we have somebody who has a question, please call. The number is 622-WOCA. In the studio, we have some experts on your health. Colorectal cancer is what we're focusing on. Dr. Angel Caban is who you heard right there. How did I do, Caban?
Yeah,
Caban?
good.
And Phyllis Albertson is here. And Kelly Ryan, we haven't spoken to you yet, but we will. And it looks like the phone is ringing. Okay, let me take some calls. 622-9622. You will need your headphones to be able to hear the callers. So let me push a couple of these buttons and say, good morning. Thank you for calling. You're on the air. Are you there? How come I don't hear them? All right, let me try another one. All right, good morning. You're on the air.
Yes, good morning. Just today on this radio station on the national news came out about a brand new test that tests, I believe, there's blood in your stool. And it's been very encouraging, and they say it's 90% effective as far as determining whether or not you have a problem. What is your opinion on this particular procedure, and would it be helpful to have that done?
So I didn't hear the news this morning, so I can't put too much emphasis on that. I would say for colon cancer, the routine nowadays is mainly to get a colonoscopy for screening. And if you're diagnosed with cancer, there's some tumor markers that we follow. It's a blood test that we follow after that to see if the cancer is either under remission or coming back. But I haven't heard of this particular test that you mentioned. If you can maybe say a little more details, I might be able to.
Do you know any more? No, he hung up. He's listening. So that would be something we have to look into. Mm-hmm. So when a man goes in for his prostate exam, is that the same time that the colorectal exam is done, or do you have to ask for that specifically?
So it's different. The prostate exam is pretty much a digital rectal examination.
Right. The same area, right?
If you had a low rectal mass that pretty much, 8 to 7 centimeters, you can feel them. But the colon is, has a few feet long. So,
okay.
So definitely, just by you doing a prostate exam, you're not clear.
Okay, so it's close to the door, the prostate, and everything else is far away. So you use a periscope or something?
So you use a colonoscope. It's a long scope. It's probably about 10 feet long.
Wow.
The patient under sedation has a camera on it, and you navigate through the entire colon, and under a nice high definition TV, you see the entire length of the colon.
Really?
The good thing about colonoscopies is there's other modalities that you can use for screening. There's some of the newer ones is a CT colonography, it's like a CAT scan. The problem with those is that they are diagnostic. They can be, they can see a mass, but you can't really treat it. With the colonoscopy, you not only see the mass, you can get a biopsy, you can remove the polyp, you can take pictures. It'll give me a good idea when a patient comes back and brings the report, and I can see the mass itself. It's like, oh yeah, this mass is, is very worrisome for cancer or something like that.
Wow. So while you're in there, you can actually do the procedure rather than just take notes and say, here it is. It's 3 feet in.
If it's a small and superficial mass, you can a lot of times remove it.
Wow. All right. We do have, I have so many questions about that. Good morning. You're on the air. Thank you for calling. Are you there? Oh, all right. The phone number, if you want to call, is 622-9622. It's an important topic, and if you have any questions, maybe somebody you know is going through this right now, and you have some questions about their health.
Does the amount someone urinates per day, can that be an indication you might have colon cancer?
You mean in the amount of bowel movements you have a day?
Yes.
Not
the
really.
urine itself.
That varies between person by person, right? For a person, it might be normal to go to the bathroom once a day or twice a day. For other ones, might be normal to go 3 times a day. Mm-hmm. So it really depends on patient by patient basis. Now, if you notice a big difference, let's say you used to be very regular, you used to go 3 times a day, and then all of a sudden you notice that you go once a day and you change a different caliber in the stool, like they're narrower or they're bleeding, then you gotta start, why this change. And on top of that, if you're losing weight for no reason, those are all like red flags that you gotta, pay attention to.
And we do have another phone call. Thank you for calling. Good morning. You're on the air.
Good morning. Could you talk about the difference between hemorrhoids and colon cancer? And I'll hang up and listen.
Thank you. Oh, good question. Yeah.
So there's a big difference between hemorrhoids and colon cancer. Hemorrhoids are benign. A hemorrhoid is a blood vessel that lives in the anus that pretty much works as a cushion to, when you have a bowel movement, it protects the sphincters of the anus and that kind of stuff. So those are benign diseases. They're normal to have hemorrhoids. Everybody has hemorrhoids, but when they enlarge, they can give pain and they can bleed. So those are considered abnormal, and you can do different things to improve that. Colon cancer is a malignancy, obviously, and it's a totally different thing, and it's treated a lot different.
So I can understand why if somebody has a bleeding hemorrhoid, they might think they have cancer.
Yes, they could. Every time you have rectal bleeding is not normal. Having rectal bleeding is not normal no matter what. And there's multiple things that can cause that. Even if it's a stomach cancer can cause bleeding. It's just that usually colon cancer has red blood instead of darker blood.
Right.
Because if the blood started in the stomach or in the esophagus, it gets processed through the intestines and eventually becomes darker when it comes out. If it's closer to the anus, it's brighter. The hemorrhoids are pretty close to the anus, so they're bright red blood.
Wow.
It can be substantial enough that you can see it in the water in the toilet, or it might be just a little bit that is in the paper. So that's not normal. If you have rectal bleeding, you should get it checked out and see why. Now, it's more common to have bleeding because of hemorrhoids than to have a cancer. But that doesn't mean that, if you can really distinguish one or the other just because you're bleeding.
So once it's cured, once the cancer is cured, is it likely to come back or not likely to come back?
So the good thing about colon cancer is that if you find it on time, the chances that you're going to be cured is really good.
Really good, okay.
And early cancer, that's why we promote getting screened at the age of 50.
Right.
Don't wait until you're 60, because if you had a cancer there for 2 years, we could have found it a lot earlier, and the chances that you were going to get cured was higher. So the sooner that you get diagnosed, the better. Usually surgery is the main treatment.
Right.
And then after that, it will, depending on how the specimen looks, you might require chemo radiation. And we follow those patients after surgery for several years just to make sure that the cancer is not coming back, depending on their stage. So usually they all get routine colonoscopies to follow up after the surgery. If their cancer was more advanced, some of them will require CT scans to look at their liver and other organs to see if the cancer is spreading. And we also get that blood test that I mentioned before, where it's a tumor marker that is fairly specific for colon cancer. Whereas that number starts to climb, it starts to increase the incidence of the suspicion that this is spreading.
Oh, really? That's kind of a red flag, huh?
Are these all the kinds of questions, Phyllis, that you have to answer on a daily basis from the patient and their families? Because you're kind of like their roadmap to health.
Well, yeah, but again, I get them after they've already come in with a problem, because I don't see them, more if you're in private practice, you might see somebody that goes to their primary physician with a bleed, or something like that. So I get them when they're already in crisis with that. So yeah, all these questions.
Yeah, I imagine you've got to be somewhat of a psychologist. I think we mentioned that before.
Sometimes.
When you spoke. Kelly,
Yes, sir.
one question that I have is, especially with some of these new health care laws with insurance, are you the person we go to first to set up the appointment for the screening and figure out if we have the right insurance and all that stuff?
Yes, sir. I would be the one you would call. I would check out your insurance. I would do all of the legwork for you.
Oh, really?
Yes, sir.
So somebody listening right now, they say, I'm 59. I'm 9 years late, right? I don't want to wait till 60 because I could be dead.
Give me a call.
Just call you.
That's right.
See, that's me. I'm talking about myself here. I've never had this done.
Oh,
No.
so you should.
Oh!
There you go.
Robin has never had this done either.
There you go. No.
What are you guys doing this afternoon?
Yeah.
No, we're not.
Start your prep this afternoon.
It's not the procedure, it's the bowel prep.
Yeah, so usually the procedure itself, you won't remember. You are sedated. You really won't remember anything about it.
I've always wanted to be sedated. Is it fun?
I don't know. You hear a lot of
Take
interesting
pictures.
things when patients are going.
Really? What do you hear? So do you speak to them when they're under? I mean, do you say, "Whoa, what is that?"
No, people react different to anesthesia. Some of them, get pretty happy and they start talking about their personal life, and sometimes they make some pretty funny jokes. But for the most part, once the medicine is, really kicks in, they fall asleep and they don't feel anything at all. And some of those medications will make you have retrograde amnesia, so you forget kind of stuff that happened before. So you really don't remember the procedure for the most part. The worst part about getting a colonoscopy is what Brittney mentioned before, is the bowel prep. You gotta take a laxative to clean your colon, because otherwise you can't really see. And usually that's the day before the procedure, and you pretty much spend the whole day in the toilet, basically having diarrhea to get yourself cleaned out. That's kind of like the worst part of the procedure.
The whole day in the toilet.
Wow.
You mean in the bathroom?
Friday afternoon.
Okay.
On the
Bring in the
toilet.
TV and magazines.
A bigger toilet than I have, I guess. Okay. All right.
Well, that's extremely interesting because you do have to have everything clean and spick and span before you, as the doctor, can go in and check it out, because you have to make sure there aren't any obstructions that you could miss.
Yeah, polyps can be very small. They can be just a few millimeters in size. And if the colon is not clean enough, you can miss some of those.
So why do they have to be knocked out? Is it painful?
Oh, you won't tolerate it.
Are you 10 feet? And you're
Yeah.
Oh, 10 feet. I'm
Yeah,
not even 10 feet tall.
Imagine your prostate exam magnified to 20. So you probably won't like it very much.
Yeah. All right, we do have another phone call. Good. Oh, yeah, put in your headphone. Good morning, you're on the air. Thank you for calling.
Yes, another question quickly. Does alcohol abuse contribute to colon cancer?
All right, good
Is it
question.
alcohol
abuse, does it contribute? Yes.
A little bit. I think that the risk factor in terms of addictions that is more known to increase the incidence is smoking. And that's one thing that I emphasize the patients that smoke a lot. That they think that smoking just increases your chances of having lung cancer.
Right.
That's not true. People don't know that smoking increases the incidence of lung cancer, esophageal cancer, pancreatic cancer, bladder cancer, colon cancer.
Wow.
So that's the addiction one that is more.
Quit smoking.
Yeah, exactly. But I don't know. I guess that the alcohol depends on how much alcohol you use a day,
And see, I asked about hot, spicy foods. I've often wondered about that.
Well, usually people that have bad drinking habits don't take care of themselves for the most part. So, colon cancer is a multifactorial problem. Probably if you drink a lot, your liver doesn't work well. Your overall health is not great. You probably don't go to the doctor. You probably don't eat well at all. You might be overweight because of, you have a beer belly or something like that. So those are all, increases the chances of having colon cancer. So it might not only be related to alcohol abuse, but it definitely predisposes you to other things that predispose you to having colon cancer.
And how about secondhand smoke? Will that affect the person? That's not smoke. That's not the smoker, but the person's around the smoker.
There is some scientific evidence that secondhand smoking is not good for your health. Now, I don't know of any scientific study or anything that have proved that secondhand smoking itself just increases colon cancer. I will assume it does. If you're exposed to it,
Every day.
It's really the only thing I want to be secondhand is smoke. I think secondhand smoke is better than new smoke. I think. I'm not sure. All right. Good morning. You're on the air. Thank you for calling.
Hello.
Hello. Good morning.
I'm calling for to get that guy that comes on Monday for the auto, his number.
Oh, well, call back call the office number 732-8000. Okay.
What number?
732-8000.
Oh, 8,000. Okay.
Yeah, thank you. That's why we do live shows, so we can get calls like that when we're talking about the colon. So the important takeaway message from here. Let's see what my conclusion will be. It's important to get an exam.
If you're over 50, you should get screened.
And the way we do that. Let's see. Kelly, we call you?
Yes, sir.
You're our first base, right?
Yes, sir.
All right.
Nowadays, the primary care physicians are very good about sending the patients or recommending some sort of screening after the patient turns 50.
But they don't do it, right? Your primary physician
Usually they don't. The majority of the colonoscopies are done by gastroenterologists. So they usually refer the patient to a gastroenterologist. They get the screening colonoscopy. If they found something suspicious, they usually biopsy it. And
so you're not doing that test. You're the guy after that test.
Exactly. I do the operation when you need it.
So I don't want to see you. No.
You can, and we can facilitate that for you.
No, that's okay.
If you don't have a primary care doctor and you need somebody to send you a referral for a colonoscopy, we can do that. That's not a problem. But usually the patients, when they come to me, is because they found a mass that is too big to be removed through the colonoscopy.
Okay.
So they require an operation, and that's where my expertise is. And I was fortunate enough that during my surgical training at the University of Florida in Gainesville at Chance Hospital, I did a lot of advanced laparoscopic surgery. So most of I will say 90% of the colectomies that I do, they're all laparoscopically.
Wow.
And a good portion of them are completely laparoscopically. Which the difference between a laparoscopic operation versus an open operation for colon cancer is it has quicker recovery, so you are in and out of the hospital for the most part sooner. You have smaller incisions. Instead of having like a big incision that covers your entire abdomen, you have very small incisions throughout your abdomen. And with some special instruments and a TV screen, we do the operation that way.
Oh, wow.
So the chances of having wound complications is significantly less. Chances that you can develop a hernia later on is lower. The chances, you're going to go back to for older folks that like to play golf here in Ocala, they can go back to playing their golf a lot sooner than if they have their operation open. So I think one of the reasons why I came to this community was to bring some of those skills that are lacking here and try to offer the people in the community more advanced surgical options.
Where did you move from?
I was a resident, as I said before, at Chance. Then I went to Texas at UT Southwestern for a year to do a fellowship in advanced laparoscopic and bariatric surgery. And then I went back to Chance, and I was a faculty at Chance for 3.5 years. And there I did a lot of complex laparoscopic cases, not only for weight loss surgery and upper GI surgery, but also for colon cancer.
So has the technology in the years you've been doing it made it easier for you, more comfortable for the patient?
Absolutely. I think, I learned how to do these operations for the most part laparoscopically. And I think that's a big advantage of some of the younger surgeons, that you adopt those technologies easier and sooner than surgeons that they've been in practice for a long time now, because they needed to learn that afterwards. They were more comfortable doing these procedures open, and now they got to change their practice to try to do them minimally invasive. In my case, I learned to do them minimally invasive, so that's my comfort zone. That's how I do my procedures better. So I think in my training, it really helped to do it laparoscopically, and the patients do better and they get out of the hospital.
Sounds like the best way, yeah. Is there a rehab time after this?
It depends, depends how you recover from surgery. It's an operation. You can have complications. Anybody can, especially in older individuals. Even complications that are not related to the operation itself. You can have complications from the anesthesia, like a pneumonia or a heart attack. Those people, if you're 80 years old and you get a colon operation and you get a heart attack on top of that, you might end up requiring going to a rehab center for a couple weeks to get stronger back again, to go back home, especially if you live alone. A patient that is 55 years old, has no medical conditions, their surgery went well, usually they can go back to work, depending on what type of work they do, about 2 weeks after that. So the recovery can be faster. It really depends on what your comorbidities are, what your age is.
Well, just talking about it makes it a little more comforting.
I just wanted to add, too, that if there are people out there that haven't had colonoscopies, they don't have a primary physician, they don't know where to begin, then that's where I don't just do internal navigation, I do community navigation as well. So they can contact me, and I can get them in with a primary or a specialist or a surgeon or whatever they need.
And just real quickly, the insurance question, obviously insurance would cover the surgery. But does it cover the screening?
Yeah.
Yeah? Okay.
The majority of the insurance.
I'm not sure if I have a phone call in now. Let's quickly check. Good morning, you're on the air. Okay, no way there. It was just my mistake. Sometimes it looks like there's one and there's not. Well, some good information, and I want to make sure that we give out the contact information. That's always very important. It's not only going on the air now, but it'll be on the internet for the rest of time.
Yeah, so I have a card here. I can give it to you, but the office number is 352-291-0239.
Okay.
352-291-0239.
And if you don't mind me saying, I'm guessing it's important to Spanish-only speaking people. I'm guessing you're bilingual, right?
So I grew up in Puerto Rico, so my main language is Spanish. So I'm the only general surgeon, to my knowledge, here in Ocala that speaks Spanish. So if you are, Latin America, the doors are open.
Well, and that's why I'm asking, because I know some of our listeners either have family members who only speak Spanish, or they themselves would prefer to speak Spanish. And talking about your health, you don't want... You want to be comfortable with your language, yeah.
I had a patient when I was a resident that we performed a breast surgery for breast cancer.
Yeah.
And the next day I went to see her, and she was Spanish speaking only, and she was crying desperately. So I asked her, what was wrong with you?
Yeah.
And she's like, I didn't know they were going to cut my breast off.
Oh, man.
So the doctor explained to her everything in English, but she kept saying yes and yes and yes.
Oh,
and
no.
she didn't really know what she was getting herself into. And when she woke up and her breast is missing, then it's like, okay. So I always relate to that. So if I see a patient that is only Spanish speaking, I make sure that they understand what I'm
I did the same thing at a Burger King in Quebec. I kept saying yes, 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 yes. I got everything on my hamburger. I think we do have a phone call right now. And good morning. You're on the air.
Hello. This is Linda Coons with the Cancer Alliance of Marion County.
Yes.
I came in late on your dialogue, so forgive me if you already spoke to this, but does insurance cover the colorectal screening?
Yes, the majority of the insurance cover it, yes.
Okay, so do we have to check to be sure that the facility, the physician, the radiologist, everybody is in network? Is that been your experience before we go ahead and set up a colonoscopy or a screening, etc.?
That's always a good idea, is to check with your insurance.
Probably a good idea.
So you're well informed.
Yeah, because if you go, there's many places where you can get this procedure done, and if you can get it done in a place where it's in your network, it's probably the out-of-pocket expense is going to be less than if you did it in an out-of-network place. So you definitely want to call your insurance, see if they'll cover it, how much they cover, and in the area where you live, what places can you have it done, and it will be cheaper.
Okay, thank you very much, and thank you for doing this today.
You're welcome. Thank you, and you're welcome. And so let's leave again. You gave the phone number already. It's on to any other numbers we need, any websites, anything like that?
Our
should do that?
website is ocalahealthsurgical.com.
Okay.
And you can find more info in there about procedures that I do and some info about myself and our clinic staff. And
Well, thank you all. I appreciate that you stayed a little bit extra, and we went over time, and I know that our listeners appreciated that. You're getting more calls now. I think they're joining the conversation late. If you missed the conversation, this has been taped as a videotape or video file, whatever you call it. It'll be on WOCA's Facebook page and the WOCA channel by 2 o'clock this afternoon. Okay. Brittney, thank you for bringing us some great guests. Brittney Marthaler at the end of the table. Kelly Ryan, nice to meet you. Thank you for coming in.
Thank you for having us.
Phyllis Albertson, nice to see you again. And Dr. Angel Caban, thank you for sharing your knowledge, your expertise with us.
you're welcome. Thanks for having us.
We will move forward. We'll take a little break and be right back.
Legally Yours, brought to you by Fuller & Fuller Attorneys at Law. On the air every Wednesday morning at 10:30 a.m. with John Fuller, a board-certified civil trial lawyer for over 25 years. John welcomes your questions, from business to complex family matters to legal disputes. So tune in every Wednesday morning at 10:30 a.m. for Legal